Hi, Lisa Fugel here again. You just finished Advocacy for the Elderly, Week 2. Great discussions on elder care, as well as the paper that you wrote on advocacy for the elderly. I would like to make a couple comments on the case study that you wrote about, which we know is Mrs. Jones, 85-year-old mother of 5 who lives in a 3-bedroom apartment with her husband. She and her husband live on less than $3,000 a month, Social Security benefits. They are on Medicare, have no drug plan, and she is now being placed on a medication that costs $365 a month, and they can't afford it. So your job was to figure out how to advocate for this patient. You all did a really nice job advocating for her. The focus first was on the medication. Was there a way to decrease the cost? Could there be another brand that's used that might be a little bit more affordable? Was the physician in on it? You looked at collaboration, getting the physician involved, getting the nurse involved, getting the patient involved, the insurance company. Would the physician offer free samples to get the patient started on this medication while trying to figure out how to manage the cost of this medication? So nice job looking at all of that. One of the things that I wanted to do is talk a little bit more about the additional information that was provided by some of you, because you did a nice job looking outside the box and not just focusing about decreasing the cost of the medication itself, but looking at how the patient could, and the family, the patient and the husband, could manage their money better overall, which then could help them not only pay for the medication, but maybe allow them to better offer better healthcare solutions in general. So some of the suggestions that were offered were looking at the Medicare insurance. Was there an opportunity to get on the drug plan Part D? Would it be a benefit at this point, because getting on Part D right now might cost them more than the monthly cost of the drug itself based on the late fees? So looking into that as at least as an option, but also looking into other supplemental programs such as the Supplemental Nutrition Assistance Program, looking at low-income energy assistance programs. Those are all other possible solutions of decreasing the money that they're spending that would maybe allow them to pay for that drug if there was no other ways to decrease the cost of that drug on a monthly basis. So nice job looking outside the box. One of the things that I do want to talk about for this week, which we know week 3 is on safety, and you'll talk about domestic violence situations, and your case study is on a 30-year-old homeless man who has a heroin addiction. And we all know that the opioid crisis is a big problem. There's a lot of talk about it in the media. But the reason I want to talk about this right now is because of the great work that you did this past week and kind of looking outside the box and looking at other solutions. I want to share with you an article that I found. It was actually by the Robert Wood Johnson Foundation. Columbia, Georgia region, Oregon, and Washington, they kind of did this collaboration, and it talks about community health workers. So I'm just going to click over here real quick on community health workers. I'm not sure how much you know about community health workers. When we think about it, typically what comes to mind for most is maybe a VNA nurse or home health aide as community health workers, but there's really more to it, and there's a lot of discussion about community health workers, not only in Massachusetts but across the United States, looking at the definition of a community health worker, looking at what the educational level should be for a community health worker, because what they found was the more community health workers there are reaching out into the community, and especially vulnerable populations, there's better patient outcomes. So going back to this article was pretty interesting because it talked about regions where there really wasn't good communication, very poor population, not getting what they needed. And one of the needs was nutrition. And after they sat down together, they did they did a survey, what were the needs out there. One of the things that they came up with was this VeggieRx program, and it was pretty interesting. So community health workers could basically give a prescription for $30 each month to allow them to get fresh fruits and vegetables, which was phenomenal because part of the survey showed that they didn't have enough money at the end for nutritional needs. It helps with certainly vulnerable populations such as pregnant women, diabetics, etc. But this was really a great catalyst for other collaborations. So in this article it talks about coming together, different community practices coming together, and one of the things that they're looking at is a dental program. So it was really interesting. I wanted to share it with you because community health workers are an up-and-coming thing, and they really are going to help the vulnerable population. Seemed appropriate to share with you at this time, especially because the case study that you're working with this week is on the opioid crisis. That's it for now, my little tidbits for the week, and I look forward to reading your discussion and case study.